So there are two types of diagnostic aids that we mostly use. So first is called essential and supplementary. Now essential are the diagnostic aids that you have to take. Like you cannot skip on the essential notes. The first and the foremost and the most important is case history. You have to take the case history. You have to ask what are the chief complaints. You have to ask of any past history of medical conditions and a lot. So case history is one thing. Then it's the clinical examination. You check the patient clinically. Study casts. These are the models. You can take digital models as well, or you can take models and get them digitally scanned as well. Anything would do. Then our IOPAs. These are the IOP. Sorry, this is the IOP. These are the bite wing and OPG. These three things you take. See, and this is the orthodontic diagnosis. Agar the patient comes to you for caries, you don't have to take an OPG. Okay, this is an orthodontic diagnosis we're talking about. Next are the facial photographs. Facial photographs help you keep documentation of what was there and why all the patients, what chief complaint patient came to us. Okay, so these are the essential. The thing that you need to remember is cephalometric radiograph is a supplemental. Okay, it is not an essential aid. This is the question asked. And then you need to remember the diagnostic setup, which was given by Kessling. Okay, which was given by Kessling. So this is one of the things. Then there is EMG, electromyography, then hand-used radiography, occlusion. These are all supplemental diagnostic aids. Now, why do we take a 3/4 photo? 3/4 photo is focused on this region. So can you see a bulge here? So this bulge is for good maxillary growth. When the bulge is not there, then you identify that the patient has flat this face, then it tells you the midfacial deformity. So 3/4 photograph is used for midfacial deformity. Next, coming on to models, what is the width of the usual width of the visual height of the model is 70 mm, 1/3, sorry. 2/3 is the anatomical part, 1/3 is the base, 2/3 is anatomical, 1/3 is the base. Anatomical versus statistic is 2:1. These are the questions that you need to just remember these. Dr. Samreen wants me to repeat something. What do you want me to repeat? This slide. So the 3/4 photo is to find out the midfacial. So I'll just remove all the ink marks here. Okay. So can you see there is a slight bulge here? Yes, dikh raha hai? Okay. So when can you see this bulge? This bulge? This area. So this area specifically this. So this area specifically tells you about a midface. So when you take a 3/4 photo, when you see a patient from this angle, then you can actually identify this area. So this is what is the focus in a. This is what is focus in a 3/4 photo. And whenever this is flat, this tells you a midface deformity. Okay. Now is the other clinical examination. In clinical examination, you see the whole body first, then you see the patient extraorally, then your patient will see the intraorally, and then you see the functional examination. So whenever you have to see from outside, examination of body, you check the height of the patient, you check the weight of the oh my god, you check the weight of the patient, you check the posture. If a patient is a mouth breather, then most commonly they keep their head tilted backwards. Okay, they keep their backs slouched. You also check the posture in sitting. You check the posture in standing. You check the posture in sitting as well. Okay, then you check how the patient walks, not essentially in 6 inches heel, but you see how the patient walks. And the body build. So body build classification was given by Sheldon. You need to remember it. It has been asked once in exam. So ectomorphic is thin and lean, which is also called aesthetic. Mesomorphic is an average size, which is called athletic. And endomorphic is stout, short and fat is endomorphic, which is also called plethoric. So you need to remember all these words. The next thing that you see is cephalic index. You see how the head is there. In cephalic index, what you have to see, width by height. So this is the width and height. So brachycephaly is normal, dolichocephaly like short and stout. So this is short and broad. And mesocephaly is? No, I think I've said wrong. Mesocephaly is normal. Brachycephaly is long and narrow. And this is short and broad. Dolichocephaly. Meso is the normal. Okay, what is the normal value of cephalic index? So the normal value of cephalic index is 75 to 79.9. Brachycephalic, what is the range? So normal is 75 to 79.9. Brachycephalic is, what is the range? It is more, which is 80 to 84.9 and all. Yeah, actually, yes. I'm sorry. So Dolicho, these photographs have been, I have like put the photograph in a wrong way. So images are altered. Brachycephaly is short and broad. Dolichocephaly is long and narrow. Yes, you're correct. Thank you. Who's that? Dr. Priyanka, new batch. Thanks a lot. So brachycephaly is broad and flat. Isme you have to see the dental arches also. In brachycephalic, there are broad dental arches. And in dolichocephaly, there are long and narrow dental arches. Okay. So in brachycephaly, the range is 80 to 84.9. In dolichocephaly, it is less than 74.9. It is like, remember like this, 75 to 80. Okay. 82. There is a difference of 5. 4.9 actually. And less than 75. So this would be easier. This is meso. This is brachy. This is dolly. Okay. Next is the facial index. You see the face, and face may be, so you need to remember one thing. In cephalic index, it is the width by height. Width by height. While in facial index, it is height by width. So it's opposite. So you need to see how the height is measured. Height is measured from nasion to nathion. Okay. And width is measured by zygomatic width. Okay, so these are the 2 points that you need to remember. Now, in that also there are meso. You need to remember the normal value. So normal, it is called prosopic. So mesoprosopic, you need to remember the normal value, which is 85 to 89.9. Again, 85 to 90. Okay, URI would be, so URI would be 80 to 85, and leptoprosopic would be 90 to 95. Okay, so uriprosopic and lepto is longer face and uri is shorter face, broad and short face. Okay, now we are going to discuss about aesthetics. Now, what is aesthetics? Aesthetic is largely divided into 3 types, three divisions: macro, mini, and micro. In macro, you see the frontal and the profile view. You see the patient from the front and you see the patient from the side. So that is macro. When you see the lips and the teeth, that is the mini aesthetic. Okay. And when you see only the teeth and the gingiva, then is the micro aesthetic. So these 3 terms are important, and we will discuss everything one by one. Okay. So first is facial symmetry. Any face is not bilaterally symmetrical. Any face. So it is always apparently bilaterally symmetrical. So what we have done is we have cut this patient's face in half digitally. Okay, not in reality. And we have made a mirror image of the left face and pasted it on the right face, and we have mirror image the right face and pasted on the left. So this is how these 2 photographs look like. This is called photo montage. So this shows that this face is not symmetrical, but it is apparently symmetrical. So we always call it apparently bilaterally symmetrical, because it is no face is completely symmetrical on both sides. So it should not be visibly asymmetrical. Okay. The next thing is we see the rule of fifths and rule of thirds. What is that? You divide the face into 5 segments. So side of the ear, lateral side of the eye, distal side of the eye, medial side of the eye, and these are the marks. So you just check for the symmetry in the vertical fifths. Width of the nose is here. Width of the mouth is between the interpupillary line. So interpupillary line define the width of the mouth. Width of the nose is in the middle third. Then the vertical 3 from hairline to front, like nasion, to the base of nose and chin. Okay. So the upper lip comes in the upper 1/3 and the lower lip goes in the lower 2/3. So if there is some asymmetry in the patient, then you have to see in which fifths or which thirds there is asymmetry. So whenever there is an asymmetrical patient, you have to judge at the vertical fifths and horizontal thirds. Next is a facial profile. How do you say the patient is convex, straight, and profile concave? So there are two ways to find it out. So first is you take 3 points: nasion, subnasal, and pugonium. One pugonium. Okay. The other points are bridge of nose, base of upper lip. Now these are 2 different scientists who have said this, and the last is chin. Okay. So if the question is from any of these 3, so you would understand, or these are 3 points. These both are same things, but 2 different scientists have given them different terms. So you take nasion, subnasal, and pugonium, and you draw line. So this is a convex, this is straight, and this is a concave profile. So facial profile has points, so you need to remember the points. Okay. Next is facial divergence. Now, what is facial divergence? Inclination of lower face to forehead. So what you do is you take lower face and you take forehead and you draw a line. Okay. So posterior divergence is that the lower end of the line is backwards. In straight, it is in the line, and in anterior divergence, it is in the front. Okay, so you have to see the inclination of lower face to forehead. Posterior divergence, chin is back with respect to forehead. In straight, chin is in line with the forehead, and in anterior divergence, chin is in front of the forehead. Okay, the points of facial profile are nasion, subnasal, and pugonium. Okay. Other scientists has called it to be bridge of nose, base of upper lip, and chin. I have a bad handwriting. No, yeah, it is very hard to write with a digital pen. So that's the reason. Now, lip competence. What is lip competence? Lip competence is the distance between the lip during rest. When it is touching, it is called competent. When it is not touching, because of teeth, it is called potentially incompetent. It should be potentially competent, but the scientist who has given this term has given it like this, so you have to remember it like this. The term, it is not correct, but still, just remember it like this. And if teeth are not the reason, then they are incompetent. So what is the distance? That is more than 4 mm. Okay, if the distance at rest is more than 4 mm, then you call it lip incompetence. Okay. Now, what are everted lips? Everted lips are lips like this because of high mentalis activity. Lips like this because of high mentalis activity are called everted lips. Next is nasolabial angle. So how do you draw nasolabial angle? You put at the base of the nose at the like this and till the upper lip. So this is how you draw a nasolabial angle. This photo is not actually correct. It should have been like this. Okay, so nose should have been like this. तब जाके acute होता. This is not actually acute. This diagram is not correct. So this is normal, and this is obtuse. Can you see obtuse? So the facial nasolabial angle is basically divided into two parts, like straight line parallel to the FH. So this is upper nasolabial angle. This is lower angle. So upper angle tells you about the inclination of the nose, and the lower angle tells you about the inclination of the lip. So this is nasolabial angle. What is the normal value? Normal value is 110 degrees. So we have completed the facial aesthetics. What is that? Macro aesthetics. We have completed macro aesthetics. Now we are going to see the mini aesthetics. So what is mini aesthetics? When we assess smile, that is the mini aesthetic. We see how the teeth are related to smile. Okay. What kind of smile we see? We see social smile. We don't see a emotional smile. We see only social smile, like a posed smile. Posed smile we see, because that is the smile we are concerned about in orthodontics. Okay. So first variable is smile arc. What is smile arc? Smile arc is upper lip should track the teeth ka curve. So the teeth curvature should be tracked by upper lip. That is called a smile arc. So if you see this patient, she is having a Dracula's smile because her teeth are straight while her lip are like this. So the edge of the lower lip, edge of the teeth should follow the upper lip curvature. So this is a good smile arc. This is a bad smile arc. Okay. The next thing is buccal corridor. Buccal corridor. Buccal corridor is the space between the distal, between the distal of the inside of the teeth, inside of the cheek and the distal end of the teeth as visible on the smile. So this is the buccal corridor. Okay. So in this patient, it has a normal buccal corridor, and this has a wide buccal corridor. It is also called posed and emotional smile are not the same. Posed and social smile are same. Posed and social smile are same. So, Dr. Vishali, please mute yourself. Yeah. So this has a wide buccal corridor, and this has a normal buccal corridor. So wide buccal corridor is because of the constricted maxillary arch. Okay, wide buccal corridor is because of the constricted maxillary arch. What is the ideal value? Ideal value should be 13%. Okay, maximum it can be 17%. Buccal corridor is this black space. Can you see this black space? This is the buccal corridor. It is seen from the surface of the teeth to the inside of the cheek. In this patient, it is a very normal buccal corridor. Okay, and this is large buccal corridor. What is the normal? Normal is 13%. 13% of intercommissural width. Okay, maximum can be 17%. Now, large buccal corridor is because of the constricted maxillary arch. Okay. Next, what is the next? Isme buccal corridor is also a problem. Apart from that, it is gingival display. These are the same patients. This is taken from Profit. These diagrams are taken from Profit. These are the same patients, but these are not the same patients. These are different patients. Next is gingival display. How much should be the gingival display? What is ideal? Gingival display is gingival display during smile. Ideal is 2.3 mm. Okay, ideal is 2.3 mm of tooth coverage. These tables are given in profit. If you want to go back, you can look at that. Okay, so less, if more gingiva is visible on smile, it gives you a natural appearance. It gives you more young appearance. Okay. Next is occlusal cant. Can you see this patient has her upper jaw deviated like this, and you can see it in this diagram also. So occlusal cant is the next thing. It should be 0. There should be no occlusal cant. Okay. Next is facial midline and dental midline. Okay. Next is upper dental midline to face. Upper midline. So upper midline is there here, and the facial midline is here. So this actor has a deviated midline, right? This is like by far the most famous actor, and he doesn't care about midline. So I don't know what the orthodontic patients should be caring about. Anyways, the next is upper dental midline to face. Next is central incisor height. The central incisor gingival height. So this and this. So in this patient, the central incisor CI gingival height is not fine. What is next? Next is LI CI gingival height. The same patient, you can see lateral incisor gingival height is almost similar to the central incisor height. Here there is a difference. So there should be a difference. How much difference can be there? There can be 4 mm difference, and 4 mm lower. It should be minus 4 mm. Why is it called minus? Because lateral incisor gingival height should be lower than the central incisor gingival height by 0.4 mm. Okay. Next is upper gingiva, central incisor and lateral incisor ka step. If you see in this there is no step, but in this there is step. So how much the step should be? This step should be the step should be 1.2 to 1.4 mm. You need to remember this value. 1.2 to 1.4 mm. And the last is overbite. How much should be the overbite? Ideal is 2 to 2.3 mm. Okay, this covers the mini aesthetics, which is the smile variables. Next, we are going to discuss about microaesthetics. Now, microaesthetics is when you see the relationship of teeth to the gingiva or teeth to teeth. Okay, so the first relationship that we are going to see is tooth proportion, which is also called golden proportion. Now, what is golden proportion? Golden proportion says that with every next tooth should be 62% visible of the first tooth. Now this should be 62% of this tooth. Canine should be 62% of lateral incisor. Premolar should be 62% of canine, and so on. So golden proportion is 62%. Okay, so remember this value. Next is the width versus height of the tooth. So if the height of the tooth is 10, the width should be 8. Okay, so the ratio is 80%. Width by height is 80%, right? Next is gingival height or the gingival zenith. Now, what is zenith? Zenith is the highest point on the gingiva. So if you see the central incisor, this highest point is like distal to the central axis. In lateral incisor, it is at the central axis, and in canine also it is slightly distal. So you need to remember, of maxillary central incisor, it is distal to the midline. In lateral incisor, it is on the midline, and in canine, it is distal to midline. Okay. The next is gingival shape. How is the gingival shape? So in central incisor, it is basically half ellipsoid. So if you draw if you make a circle, then it is half ellipsoid or central incisor. For for lateral incisor, it is semicircle. Sorry, circular, and in canine, it is ellipsoidal but vertical. Okay, Dr. Mami wants me to repeat zenith. Zenith is the highest point on the gingiva. Okay, in central incisor, the highest point is slight distal to the central midline. For lateral incisor, it is on the midline, and for canine, it is distal to midline. You'd have to remember the zenith. Zenith is like the height, the highest point. This. Okay. Next is the shape of gingiva. Shape of gingiva. For central incisor, it is ellipsoid but horizontal. Horizontal half ellipse. Horizontal half ellipse. So if you draw an ellipse here, it would be like this. Okay, so this part is half horizontal ellipse. For a central, for a lateral incisor, it is circle. It is part of a circle. And for canine, it is vertical ellipse. So the canine would be, the height should look like this. You understand this shape of gingiva? For canine, it is vertical half ellipse. Did you understand, Dr. Tejasvi? I need an answer. We are running short of time. Okay. Next are the connectors. Connectors is the connectors is the portion for which tooth comes in contact. It is 50% for central incisor, 40% for lateral incisor and central incisor, and 30% for canine and lateral incisor. You need to remember this. Okay. Dr. Sonam has asked me, ma'am, shape of gingiva means this shape. So if you see this shape and if you make half of it, so it is like this. So that is what I'm showing and on the tooth. I'm not showing on the tooth that shape. I'm showing how you can consider it. This is a part of circle and this is vertical ellipse. This is horizontal ellipsoid. That is what I'm showing. Okay. So connectors you need to remember 50%, 40% and 30%. Okay. The next is dark and dull shade. So here the canine has a darker shade of canine. So canines are basically the most dark shade. These are the 2-3 things that you need to remember. I've just put it on the slide so that you can read it because they have been asked in questions and somebody has asked me. Dr. Pragya has asked me, connector and the contact area are one and the same thing? Yes. Yes. Contact area and connector are the same thing. Okay. So these are the ratios that you need to remember. 1/16 and 6.6. Nasal width by height is 70%. Okay. Now we have completed this. Now we need to revise a few things. Now let's get back. I think the link has been shared in your group. Smile arc is not for the lower lip. Smile arc is the curvature of the teeth following the upper lip. No, take a second. Yes. Smile arc is the curvature for the lower lip. Yes, it is on the lower lip. I'm sorry. Smile arc is the lower lip. Dr. Yogesh, in anterior teeth is not in contact area, it's contact point. No, it's not contact point, it's contact area in anterior teeth. Sometimes it's a contact point. Okay, I'll give you an example. So sometimes in the teeth, there is a contact point in the anterior teeth. So what happens is, there is a space here, which is called black triangle. In that case, you have to treat this black triangle. So when there is a contact point, then there is a problem called black triangle, this area. So you need to correct it. You need to treat this black triangle. And there's a very good article by Dr. Sudha Sundareshwaram. She is, I think, the iOS president also. And she has discussed about the treatment of black triangle. We're not going to go there. Let's not discuss that. But in the anterior teeth, there should be a contact area, which should be 50%. Difference between smile arc and lip line. Okay, so lip line is, don't judge me on the quality of my diagram. So when the teeth are here and when you smile, the lips line is here. So this is a high lip line. Okay, it has nothing to do with the curvature. Smile arc is of teeth with the lower lip. When it is the upper lip, it is the high lip line. And when you smile, your lip will come like this, then it is the low lip line. Okay, this is a high lip line. Let's revise whatever we have read here. Falling, I have just told you the answer. Anyways, lateral ceph is not a essential diagnostic. In nathostatic models, this I have discussed when we were discussing the facial, when we were discussing Simon's classification. Okay, this we have discussed when we were discussing Simon's classification. Yes. So the answer is 2. Maxillary cast parallel to FH plane. Nothing is said about mandibular cast. Mandibular cast comes in occlusion with the maxillary cast. Okay. 3/4 profile photograph is used to detect what? Midface deformity. Dr. Yamini Purohit has raised hand. Could you tell me what is the issue in the chat box so that I can resolve that? Midface deformity. Very good. Dolichocephalic facial pattern is associated with which kind of dental? So dolichocephalic is long and narrow face. So long and narrow face is related with the long and narrow dental arch. Very good. Facial divergence is the inclination of lower third of the face with the forehead. Very good. Yes. Incompetent lip refer to yes. Inability of lips to cover the incisors in mandibular relaxed position. It is not in occlusion. We always judge the facial and profile photographs in a relaxed position. Okay, so the facial and profile photographs are taken in a mandibular relaxed position. We do not ask the patient to occlude the teeth. Okay, everted lips are associated with all we know is that everted lips is associated with hypermetallic activity. Okay, but still, if there is a question, then what can we think about it? It is basically the decreased anterior facial height. Why? Because when the facial height is decreased, then lips get very less space. This is why they become everted. So it is related to the decreased anterior facial height. You need to remember this point. It is not orthognathic mandible. Orthognathic mandible is normal mandible. It is associated with decreased anterior facial height. Orthodontic diagnosis focuses on emotional smile, social smile, full smile, coming smile. It is on social smile or posed smile. Mentalis activity, mentalis muscle contraction causes lower lip too. Can I discuss this question tomorrow? I'll just check the reference out and I'll come back to you with this explanation. And whosoever has attended my previous lectures also, this was something. I'll come back to you with this question tomorrow. Okay. So there are two things: Klein habits and mentalis activity. Okay, I'll come back to you with this question tomorrow. I cannot explain it to you right now. I'll just check the references and I'll let you know. Okay, let's discuss this question tomorrow. Lip is supported by relationship of lip edge and facial surfaces of teeth. Labial sulcus between the teeth. See, it is not supported by sulcus. So this is wrong. Relationship of teeth and tongue. Tongue is not supported. So this is wrong. So none is the option, or relationship of lip edge and facial surfaces. Actually, it is supported by the facial surfaces and the lip edge. Yes, answer is 1. Okay, so we are done. We have